to introduce Dr. Dominick Angiolillo. So welcome to Israel. Very nice to have you here, and I'm really honored and pleasure to do this introduction. Dr. Dominick Angiolillo is an associate professor and medicine and medical director of the cardiovascular research program at the College of Medicine in Jacksonville, University of Florida. Professor Angiolillo is a staff cardiologist and interventional cardiologist at the University of Florida Health System. His clinical as well as research main interests include ACS, interventional cardiology, which is mainly almost everything, but especially important to us, it's antithrombotic therapy. His largest international recognition has been for his major contribution in the field of thrombosis. In particular, Dr. Angiolillo has performed seminal studies of platelet function and antiplatelet drug response, including some genetics studies. He has authored, please pay attention to this number, not less than 300 peer-reviewed articles and 30 books chapter, and he is the editor of his own textbook on antithrombotic medicine. Dr. Angiolillo is an active member of many cardiovascular associations, including in the States and in Europe, and he is in the editorial board and reviewers of numerous leading cardiovascular journals. Dr. Angiolillo, please.
Good afternoon, everyone. Thank you very much for the kind introduction. And again, I want to thank the Israel Heart Society for the kind invite, and obviously I'd like to thank the sponsors of today's symposium, Lily, for your hospitality and for the invite and for setting up such a nice venue. So my goal today is to speak to you over the next 20 minutes, and I'll make sure that I'm on time, about how to optimally tailor antiplatelet therapy in patients with non-STEMI. And let's see if this works, okay. And you'll see from my presentation that I will also be giving you a lot of practical perspectives and what my interpretation of the trial data is. These are my disclosures. So I always like to start off with pathophysiology. As you can see here, this is the way you have the development of a thrombus. When you have rupture of a plaque, you have activation of two pathways, a cellular pathway represented by platelets, and then the coagulation cascade. And one thing that we tend to forget many times as interventional cardiologists is that there's an interplay between the two pathways. As you can see, the surface of the activated platelet is the main source of thrombin, and thrombin is the most potent inducer of platelet activation. However, this pathophysiological mechanism is important when we distinguish the different types of antithrombotic therapies that we use in ACS-PCI patients. I always show this to my fellows because many times there's a lot of confusion. What's an anticoagulant and what's an antiplatelet? You always need to look at the pathophysiology and make a distinction. So the antiplatelets are aspirin, the P2Y12 inhibitors, and the glycoprotein 2B3 inhibitors. And the anticoagulants, we have the anti-2s, direct and indirect, and the anti-10s, fondaparinux and rivaroxaban, although this is not approved in the United States. And my goal here today is to speak about the oral therapy, and therefore aspirin and the P2Y12 inhibitors. Now, when we speak about the optimal antithrombotic cocktail, I always start with defining what's the clinical presentation of the patient. And I think that we would all agree that we distinguish our patients according to having stable coronary disease, unstable angina, non-STEMI, and STEMI. I've been asked today to speak about unstable angina, non-STEMI, although you'll see from my presentation I'll also speak a little bit about STEMI. So why is a non-STEMI important? Non-STEMI important because it represents the vast majority of our ACS patients that we are treating today. This may be also in part due to the fact that with changes in definitions and introduction of high sensitivity troponins, we're picking up more of these patients. But what I'd like to focus your attention on is the number over here. We have almost a million patients in the United States who have a new NMI, and this is another striking number, for me even more striking, that almost half of these patients are going to have a recurrent event. And this is going to be also useful for my presentation. This is how these agents work. Very simply, aspirin is an inhibitor of the COX-1 enzyme and therefore blocks the generation of thromboxane. And we have the P2Y12 receptor inhibitors, which in the past we didn't know it was P2Y12. We just knew about ADP. It was only in the early year 2000 we identified the subtype of P2Y12. And we have ticlopidine, clopidogrel, and prasugrel, which are respectively a first, second, and third generation tyrosine, and ticagrelor, which is a first-in-class CPTP. And what we have learned over the course of over a decade that dual antiplatelet therapy is a good thing, and this has been shown with clopidogrel in the CURE trial, in the TRITON trial, and in the setting of STEMI in the CLARITY and COMMIT trial. So definitely clopidogrel is shown to be a very efficacious drug and a very important drug, and it's one of the reasons why we are where we are today. Nevertheless, we've learned about the limitations of this strategy, which is the concept of response variability. And we've also learned, also from lead investigations coming right here from Israel, is that this has prognostic implications where those patients with a poor response have a higher risk of ischemic recurrences. And so this leads us to the bulk of today's presentation is we definitely know that clopidogrel or P2Y12 inhibition is important, but we need to define strategies to obtain a more optimal P2Y12 blockade. And these two strategies are with prasugrel and ticagrelor. Prasugrel is a third-generation tenopyridine. The main difference with clopidogrel is that it has a more effective pharmacokinetics, therefore it generates more efficiently the active metabolite, which then irreversibly blocks the P2Y12 receptor. Ticagrelor has a different mechanism of action. We speak about it as direct acting, although 30 to 40% of the drug actually derives from a metabolite, and it has reversible binding from the P2Y12 receptor. I always specify reversible binding because some people speak about it as a reversible drug. You cannot reverse the effect. It's reversible binding. And when we look from a pharmacodynamic standpoint, I like to introduce the concept of the 3 Ps. Now, I saw right behind there is written consistent, rapid, and potent. I like to call it PPP, so prompt, potent, predictable, because they both kick in early. They're very potent and little variability. And I would say that more or less there's kind of equipoise between the two drugs from a pharmacodynamic standpoint. And the question that everybody brings up is there a winner from a clinical standpoint between the two drugs? Prasugrel and TRITON 38, ticagrelor in the PLATO trial. And in my opinion, the answer is no, they're both winners. Because both drugs found that using more potent agents in a setting of high-risk patients characterized by high platelet reactivity, both ticagrelor and prasugrel were associated with a significant reduction in ischemic events. And both drugs also showed that there was a price to pay, which is an increased risk of non-CABG TIMI major bleeding. This was shown with prasugrel. It was also shown with ticagrelor. Now, sometimes with ticagrelor, there's a lot of confusion regarding the bleeding. And people say, oh, there's no bleeding with ticagrelor. I would say that that is not true. It's not true, and I'll show you why. I mean, I've been working in the field of antithrombotics for many years, and there's no such thing of a more potent agent that's not associated with bleeding, okay? There's no such thing of a miracle drug. And it all depends on the definition, because in the definition of the PLATO trial, the CABG bleeding were also included, which accounted for the vast majority of bleeding. But when we compare apples with apples, therefore, for example, the non-CABG TIMI major bleeding or even the PLATO major bleeding, you see that there is an increase. And when we look more specifically, the number needed to harm between the two drugs, when we look at non-CABG TIMI major bleeding, is identical. Okay, so from my standpoint, both drugs are winners. The question here at this point is, when to use the drug, which one is better. Again, there are profound differences between the trials. Patient population, TRITON was a PCI trial, PLATO was a full spectrum ACS, and TRITON patients were not pretreated with a section of STEMI, PLATO yes. differences in loading dose, and difference in duration of treatment. This sometimes is underestimated. TRITON lasted almost 6 months more than the PLATO trial, and this can also account for some of the outcome data. And when we look at the guidelines, I like to follow the European guidelines because I think they're more objective, that these agents should essentially be used in everybody, with the exception of those who cannot receive the novel agents because of contraindication or because not available, and this is a class 1A. And so I think as a take-home message, and from a practical perspective, you always need to know your contraindications. And I do a lot of teaching with the ACC for board reviews, and the boards always like to emphasize where you should not use the drugs, where's the potential for harm. And so here with prasugrel, there are 3 absolute contraindications: high risk for bleeding, prior to stroke, and hypersensitivity. And with ticagrelor, there are 4: high risk of bleeding, prior hemorrhagic stroke, which sometimes is not emphasized, severe hepatic dysfunction, and again, hypersensitivity. And then we have use with caution, which are not contraindications. Use with caution: elderly, low weight, and if patients need to go to surgery, wait 7 days. With ticagrelor, because of dyspnea, use with caution patients with advanced respiratory diseases, bradyarrhythmias without a pacemaker, patients with problems of compliance. Again, these are not my definitions. These come from the both FDA and the European documents. Drug interactions, dose of aspirin, and if patient needs to go to surgery, you still need to wait at least 5 days. So let's dig in and say, when do I use prasugrel and when do I use ticagrelor? And I'm going to go into what my clinical practice is and explain to you why. These are the 4 settings where I use prasugrel: in STEMI, diabetics, recurrent ACS, and stent thrombosis, and I'll show you why. Let's start off with the STEMI. Here you see the data, the STEMI data from PLATO and TRITON. And in PLATO, you see at 1 year, there was a relative risk reduction of 13% with a p-value of 0.07, which was consistent with the overall trial. So we should not consider this as a negative finding. It's consistent with the overall trial. But what we found in PLATO was that it took at least 2 months for separation of the Kaplan-Meier curves, which is something not that typical in STEMI, because historically, we've always found that more potent agents in high-risk settings, such as STEMI, you see an early separation of the curves. Okay, you see that in 2B inhibitors, and you see that with prasugrel. And you see here there's an early separation of the curves with consistent effects over time, with a number needed to treat of 41. And the other issue is that many times in my practice, because of cost issues in the United States, we're not always able to continue long-term therapy. And so if I'm going to give a therapy where I get more bang for my buck, you can see here, this is the rationale for me using prasugrel in my clinical practice. There's been a lot of debate that in the STEMI cohort, a lot of the data with prasugrel were driven by the secondary PCI. Here's some data that I'm going to show to you, which will be published soon, removing all the pericardial myocardial infarction. There's a lot of noise, and just considering the spontaneous MI. In other words, the real myocardial infarctions. Patients go home, and they may have another MI. And when you consider the spontaneous MIs, you see here that the curves continue to separate even more, and this is the primary PCI, with a 50% relative risk reduction at 30 days, and with a P for interaction that is above 0.1. So again, in my opinion, these are very consistent data. They'll be published soon, as well as consistent data as shown from this analysis, which was just published a few weeks ago in AJC, coming from the INFUSE-AMI trial, where you can see that prasugrel compared to clopidogrel, significant reduction in MACE, also significant reduction in death, significant reduction in stent thrombosis with no differences in TIMI major bleeding. So I would say that there's little doubts on the value of prasugrel in STEMI. Let's go into patients with diabetes. Diabetes has always been kind of a hobby of mine to study, and I've had the opportunity to work in both the PLATO and the TRITON TIMI 38 analysis, so I'm pretty familiar with the data. And with PLATO, you can see here we have a 12% relative risk reduction. Now, although it goes across the line of unity, the correct way from a statistical standpoint is to say that the data are consistent. So ticagrelor is a good drug in diabetics, but it seems that prasugrel has some advantage in the diabetic cohort. As you can see, there was a 30% relative risk reduction. And this is the reason why this is also emphasized within the practice guidelines. So if I have to choose, in the absence of contraindications, this is the reason why prasugrel for me is a good drug in diabetics. A third cohort is recurrent ACS. I think this is a very important cohort. I alluded to it in the initial part of my presentation, and let me explain to you why. When we conduct clinical trials, the patient has an event, the event goes in the Kaplan-Meier curves, and it's game over. However, in real-world clinical practice, as well as in the clinical trial, if a patient survives the event, in other words, if the patient didn't die, because the patient's dead, the patient's dead, that patient can go ahead and have future events. So how do we account for this? And also because this is a main driver of cost analysis. Well, this was analyzed in the TRITON trial, and you can see here that if a patient survived their event and continued on prasugrel, there was a significant advantage, and there's also a significant reduction in cardiovascular mortality. I think this is an important take-home message. So for those who are somewhat resistant and changing therapy, one message is clear. If you have a failure to clopidogrel, you need to switch therapy, okay, because there are implications in terms of cardiovascular mortality. We published a similar analysis with PLATO, and again, I participated in this analysis written by one of the TIMI fellows, in which, although the overall events, there was a reduction, when we look at the additional events, in other words, the secondary events, this did not reach statistical significance. Again, it's a cohort to be interpreted with caution. Nevertheless, if I need to choose, I choose what my interpretation of the data allows me to think where the drug is more effective. And again, I published this and not the other one, and I believe that prasugrel has something extra in that cohort. The fourth group is stent thrombosis. We don't see too many, but I do believe that there's a particular advantage of a PCI drug that showed to significantly reduce stent thrombosis. So in those few cases, I think that we have, prasugrel represents a better option. So you see here, the take-home message is when we look at STEMI, diabetes, recurrent ACS, stent thrombosis, they're common factors. They're all high thrombotic risk. And in all these situations, there's a benefit that outweighs the risk. And these are shown to be the most cost-effective strategies. So you may ask, when do I use ticagrelor? Well, it's a very good drug, and I think it's useful in my patients with prior TIA stroke, particularly in these high-risk settings. And here you see the prior TIA stroke analysis where ticagrelor is shown to be effective. And these are high-risk patients without any considerations for harm. Second category, those patients with medically managed ACS, high-risk patient population. And you see there was also a mortality benefit, differences in trial design. And I think in the medically managed ACS, ticagrelor represents a good option, which we do not have with prasugrel because of the neutral outcomes of the Trilogy ACS trial. But Trilogy ACS, I think, is very important because it supports the safety of prasugrel. So when you're using the drug in the right cohort, you see that there are no differences in bleeding between prasugrel and clopidogrel. And the third is if you have an allergy to clopidogrel, I think that if you, just like in antibiotics, you need to switch class. Some final comments on some subsets, the elderly and the low weight. I don't have low weights in my practice. In the United States, mean body mass index of a patient on the cath lab table is 35 to 40, so I'm not that familiar with that. But we do have a lot of elderly patients. In my clinical practice, I tend to still use clopidogrel a lot in these patients, and in the high-risk patients with recurrent events, I tend to tailor either ticagrelor or prasugrel based on the presence of diabetes or a prior MI, which does have a label for prasugrel. And so this remains my practice pattern. The final comment that I would like to allude to, and I will conclude my talk, is for those patients who are pretreated with clopidogrel. Now, there are a lot of variations in clinical practice across the globe, but in many practices, a lot of patients are pretreated with clopidogrel. So the question is, can you actively switch? And the answer is yes. Now, as part of the PLATO trial, this was part of the trial design. And so it's okay to switch, and you switch with a loading dose. But we can do the same with prasugrel, and this is now updated in the label, both by the FDA and the European Medical Agency, based on trial data such as SWAP and triplet. But I'm going to show you here the mechanism. I'm not going too much into the data on why you should feel safe about switching. This is a cartoon. Here you see the platelet with the P2Y12 receptors. If you give a loading dose of prasugrel, you have more active metabolite. You block more of the P2Y12 receptors. Very simple. Here again, you have the platelet. If you give a loading dose of clopidogrel, you block less platelets. But if you give a loading dose of prasugrel on top of that, you block the remaining receptors. So what happens is the excess inactive metabolite, since it's unstable, it gets eliminated. So the take-home message here is that you cannot, there's no drug interaction, and you cannot overdose because you cannot block more receptors than those that are available. For compliance, I do need to remind you of the current indications for Effient, which is substantially what I have already mentioned to you in the presentation before. And I will conclude with this slide. There are many current controversies on dual antiplatelet therapy in PCI. For sake of time, I just focused on one, which drug. I gave you my opinion on just which drug and oral therapies, but there are many more, such as when to start, which dose, how long, et cetera, and I look forward to the case presentations to provide my further input. Thank you very much for your attention.